Thank you, Chairperson, for kind introduction. Very good morning to all. At the outset, I would like to thank the organizing committee of SLENDO for inviting me and giving this opportunity. So I will be talking on the challenges we face in localizing a parathyroid tumor. So this will be the agenda of my presentation. What is the need for localization and what are the different investigation options available starting from ultrasound, CT, MRI, PET scan and some invasive procedures like ultrasound guided aspiration with measurement of PTH in washout and parathyroid venous sampling. And finally, is there any role of intra-op imaging and the take-home message? So one thing very important we should remember, imaging is not required for the diagnosis of hyperpara. So negative imaging does not indicate that there is no need for surgery. Just we are giving stress on the localization so that the surgeon can do minimally invasive parathyroidectomy. So it makes surgery easier. So localization is not needed for the diagnosis of hyperpara. So most important thing is rather than the localization of parathyroid tumor, we should localize the experienced surgeon. If you localize in a good parathyroid surgeon, even all the imagings are negative, the surgery can be successful. That is the most important thing. So why the localization is becomes very difficult in few cases? Because the location of the tumor. So this yellow color denotes the normal parathyroid locations, and the red colors denotes the ectopic. So parathyroid gland can be present high up in the neck, like near the carotid artery bifurcation, and it may be in the tracheoesophageal groove and down till the mediastinum and in the thymus gland. So that is the problem. So even if you diagnose hyperparathyroidism, so there may not be adenoma in the normal location of parathyroid gland. So we have to, when we are doing imaging, so we have to locate the tumor starting from the carotid bifurcation till the mediastinum. So among different investigations available, we should start the imaging like ultrasound and the MIB scan as the first line investigation. Because in 60 to 70% of cases, these two investigations are sufficient enough to localize the tumor. If these two investigations are negative or if there is any discordant, then we can go to the second line investigations. So this is the arrow mark denotes one parathyroid tumor inside the thyroid gland. This is just towards the posterior side. And the parathyroid gland appearance in the ultrasound is hypoechoic compared to thyroid gland because thyroid gland is rich in iodine. So the echogenicity is more in ultrasound compared to parathyroid tumor. And normally parathyroid glands are very difficult to visualize because the size is 4 to 5 millimeter. When there is an increase in parathyroid gland either due to hyperplasia or adenoma, then only we can detect it in imaging. So ultrasound is useful for detecting parathyroid adenoma located near the thyroid gland or the upper part of the thymus. And the main problem in the ultrasound is its inability to detect the parathyroid tumor, particularly located in the tracheoesophageal groove. Because it is very difficult to reach by ultrasound probe to these areas where ectopic parathyroid gland adenoma can be located. But what are the advantages? It is inexpensive, widely available, and there is no radiation exposure. But the most important thing, the ultrasound is operator dependent. The sensitivity depends on the location of the parathyroid lesion. If the parathyroid tumor is outside the thyroid gland and it is in the ectopic area, so sensitivity is low. But the overall, the sensitivity varies from 55 to 87% in different series. And the positive predictive value varies from 93 to 97%, and the specificity similar to sensitivity varies from 40 to 98%, particularly when the parathyroid tumors are smaller, multiple, and ectopic located, the both sensitivity and specificity goes down. So next investigation is system EV scan. So this is the image showing the parathyroid tumor in the left upper parathyroid gland. So what is the principle of MEB scan? Basically, the MEB is written in the cells having more number of mitochondria. So compared to normal thyroid gland and the parathyroid gland, the parathyroid adenomas are rich in mitochondria, so that MEB scan can be retained more in this tumor, so that it can be localized. So system EV scan, similar to ultrasound, is widely available, relatively inexpensive, and it has a wide imaging field which allows the detection of few ectopic glands which are missed in ultrasound. But the problem is, similar to ultrasound, maybe also there is false positive when there will be additional thyroid nodules or lymphadenopathy in a patient with primary hyperpara. So both ultrasound and MEB are not sensitive enough to distinguish parathyroid adenoma from associated from additional presence of thyroid nodule and lymphadenopathy. And similar to ultrasound, if the parathyroid tumors are small, it is less than like 600 to 800 milligram, it can be missed. So the MEB scan sensitivity varies from 60 to 90% depending on the protocols and the disease characteristics, and the sensitivity specifically decrease already I have told in small glands, in hyperplastic glands, and the multiple in presence of multiple glandular disease, particularly in the background of multiple endocrine neoplasia. And if you will add SPECT-CT to the planar imaging of MEB scan, the sensitivity and specificity increases. So in contrast to the planar imaging, if you will do same scan with addition of SPECT-CT, the localization becomes easier. So here, this is the CT scan imaging. These are the CT scan imaging. This is the axial section, and this is the sagittal section. Here is just behind thyroid. This is the parathyroid tumor, and this is the MEB scan. So, and this is the fused image of the both structural and the functional imaging. So SPECT-CT is better compared to the simple MEB scan. And unlike ultrasound and the MEB scan, when you will add SPECT-CT in the MEB, it will be easier to distinguish parathyroid tumors from the thyroid nodule and lymph nodes. And similar to, even if you will add SPECT-CT, similar to ultrasound and the MEB, mild hyperparathyroidism, particularly in hyperplastic glands, small glands, and multi-gland disease and ectopic, still this is not sensitive enough to localize. So this is the meta-analysis showing the efficacy of MEB SPECT scan in diagnosis of hyperpara. The overall sensitivity is 81 to 90%, which is superior to only planar imaging or only SPECT imaging. So SPECT-CT is better than the planar imaging. So when there is failure of ultrasound and MEB scan, including MEB SPECT-CT in localizing the lesion, or there is any discordant, like suppose we are getting the parathyroid tumor in the ultrasound the left side, but the MEB showing the right side. So if that discordant, then we'll go to the second line investigation. So second line investigation includes 4D CT or MRI. So more compared to MRI, CT is commonly used, and the PET scan. So what is the 4D CT? Basically, The here the protocol is the contrast is given. Before giving contrast, non-contrast scan is taken. After that, there are like 2 pages. The image is taken between 20 to 40 seconds following contrast is the arterial phase, and 50 to 80 seconds following contrast is the venous phase. So in addition to 3 scans like non-contrast, arterial and venous phase, plus we are taking in time into consideration. This is the fourth dimension. That's called 4D CT. So non-contrast, arterial phase, venous phase, and time. So that's why it's called 4D CT. So here you can appreciate the most important is the arterial phase, particularly 20 to 25 seconds after giving contrast. If you can see, so the enhancement, so this red color shows the this is the parathyroid. This is the this is the parathyroid, and this is one the lymph node, and the green color is showing thyroid. So compared to the lymph node and the thyroid, so there is more enhancement in the arterial phase in the parathyroid tumor. So the main problem in distinguishing parathyroid tumor from lymph node and thyroid, which is not possible with ultrasound and MIB, it becomes easier when you do 4D CT. So here you can appreciate this is the non-contrast image showing parathyroid tumor just behind the left thyroid lobe, and this is the significant enhancement in the arterial phase in the 4D CT. So it has better sensitivity compared to both ultrasound and the MIB scan, and particularly helpful in the patient who had on a past history of neck surgery or having ectopic glands or multiglandular disease. But the main drawback of 4D CT is the very high radiation exposure, and it's expensive and availability. So here is one study from AIMS New Delhi in India comparing the 4D CT versus 4D MRI in the localization of hyperpara. So in that study, in 48 patients, both 4D CT and 4D MRI detected 59 lesions out of 61. This is basically the number of tumor breast analysis. And the sensitivity and specificity, both 4D and MRI is 96 and 66 respectively, with accuracy of 95%. But the additional advantage of 4D MRI is lack of exposure, so we can prefer this investigation in younger patients if it is available. So after 4D CT and MRI, we'll move to the fourth investigation, that's the PET scan. There are two types of PET scan available. One is choline PET scan and the methionine PET scan. Out of this, choline PET scan is better. So what is the principle of choline PET scan? In both choline and methionine PET scan, there is more the higher concentration in the parathyroid or adenoma because of expression of choline kinase in the and higher synthesis of PTH hormone in these cells. So this has specifically a role is in the patients who are having negative ultrasound or MIB scan or CT scan or inconclusive findings. So in those cases specifically, we can recommend PET scan if it is available. And additionally, short imaging time and better resolution and the low radiation exposure compared to the MIB PET. But it is not widely available and very expensive. So here is one image. You can see in the left side parathyroid adenoma, and here it is a parathyroid adenoma in the mediastinum localized by choline PET scan. So what is the role in patients having negative scan in MIB? So here is the study comparing the localization of MIB versus MIB plus PET scan. If you will do only MIB scan, there is a 12% failure rate. But if you combine MIB scan with the PET scan, there is only 2% failure rate. So there is no need to recommend this investigation to all the patients. This has specifically role if the initial 2 or 3 investigations, the first line investigations are negative. So this is another study from Chandigarh in India. Here they have compared ultrasound versus MIB versus colon PET scan. So here you can appreciate both in the patient-based analysis and the individual tumor-based analysis, the sensitivity of PET scan is better than both ultrasound and MIB. But the specificity is almost equal to the MIB scan, though it is better than the ultrasound. So PET scan, the sensitivity is better than both ultrasound and MIB, but specificity is as equal as to MIB scan, but better than the ultrasound. So here is the meta-analysis comparing the 4D versus colon PET scan. So here they have included almost 1,600 patients 4D CT and the 952 patients having colon PET scan. In per patient analysis, the PET scan having 92% sensitivity and CT scan having 85% sensitivity. But for lesion analysis, that is 90 and 79% analysis. But the important thing is, in the patients who have negative ultrasound and MIB scan, there is comparable sensitivity of both colon and CT scan. So if colon PET scan is not available, 4D CT is a good alternative. So the methionine PET scan, the performance is not as good as colon PET scan. It is almost similar to the systemic PET scan, systemic spexity. So only thing is its role is when systemic spexity is negative, we may consider. So here is the study published from Bangalore. So here they have included 54 patients out of that 36 patients underwent MIB scan, 26 were positive and 10 was MIB negative. So even if the overall sensitivity of methionine PET scan is similar to MIB scan, but the patients who were having MIB negative, out of 10 patients, 8 was detected in the methionine PET scan. So even if its overall sensitivity is less, it has definitely a role in the patients having negative PET scan. So this is a small retrospective analysis from our center. Here we have compared ultrasound with this system MIB spexity with 4D CT. So you are definitely compared to ultrasound, both spexity, system MIB spexity and 4D CT has similar sensitivity, at better sensitivity, but there is no difference between them. So 4D CT and MIB spexity almost equal sensitivity, but definitely better than ultrasound. So when these non-invasive methods, ultrasound, MIB, and 4D CT, 4D MRI, and PET scan, these 4 investigations are negative, then we can think about invasive imaging like ultrasound guided FNAC with PTS measurement in the washout fluid and the parathyroid venous sampling. But the problem of ultrasound FNAC is it is a invasive method, and there is a risk of local seeding that leads to parathyroid metastasis, and the malignancy patients it can spread the disease, so it should be very much limited to the carefully selected patients. And the parathyroid venous sampling, specifically we have to take sample from different sites, and intervention radiologists will be helpful in this case. And if the ratio is more than 2 in one vein compared to the other vein, then we can think that the area draining that the vein having higher PTS level is most likely the tumor is located. But it is expensive and the risks are there. And the last is still if free of localization not possible, we may consider intra localization. So these are different options like frozen section analysis, intra PTS assay, before and after PTS, before and after surgery PTS assay, and intra gamma, use of gamma probe, and the near investigations like near infrared autofluorescence imaging. These 4 investigations can be useful during intra-op. So which image you will decide, so that depends on the particular patient's clinical profile or the cost and the radiation exposure and local availability. That's the most important, and the experience of our radiologist. So the final message is ultrasound and system AB SPECT-CT are the initial imaging of choice for our primary hyperpara. 4D CT and 4D MRI and colon PET scan are second line imaging. And the both invasive investigations and intra imaging have limited role in clinical practice. And the combination of different imaging is more helpful compared to the single imaging. And the different factors will be taken into consideration before deciding the imaging modality for hyperparathyroidism in particular patients. Thank you for your kind attention.